Good morning, everyone, and welcome to the 2022 Annual Research Competition. To start off today's program, let's give honor and respect for our opening prayer, followed by our pambansang awit.
Dear Heavenly Father, we thank you for gathering all of us today. May you bestow your guidance and blessings so that we can enjoy and appreciate its significance in our lives. Bless everyone who are present here today, that each one of us may be able to share our knowledge, understanding, and wisdom for your glory and honor. May the various activities related to this event be a success through your intervention. We all ask of this in the mighty name of Jesus. Amen.
Mga kababayan, ang pambansang awit ng Pilipinas.
Good morning once again, and welcome to the second day of the annual research forum of the Ilocos Training and Regional Medical Center.
Today, several physicians from various departments will present their original researches and vie for the title as the year's most outstanding.
I'm Dr. Joanna Lagban Nam,
And I'm Dr. John Richard B.S. Peron.
and we will be your hosts for today's competition.
We all know the important role that research plays in our everyday lives. Everything we have and use all around us is a product of some kind of research.
And here in our areas of expertise, research constantly challenges our own knowledge and leads to vast changes in how we as healthcare professionals work.
Here at the Hospital Research Unit, we constantly see research that can redefine how we see and understand our ever-changing field of medicine.
One of these redefining researches might even be one of today's entries.
But before we proceed further with today's program, please allow us to remind you all of our house rules.
Please be aware of yourselves when your cameras are on. Remember, we can all see you.
Please keep your microphones muted at all times. This is to show respect to our speakers and contestants throughout the program. Remember, we can all hear you.
And at the end of the program, we will request for all participants to turn on the cameras for documentation.
And now, ladies and gentlemen, to formally welcome us to today's event, the Chair for the Hospital Technical Review Board Committee, Dr. Hannah Corpus.
Good morning, everyone. In behalf of the Hospital Research Unit of ITRMC, I am Dr. Hannah Corpus, current Technical Review Board Head of the unit, on study leave, which is why I am unable to be with you all live today as my class for epidemiology coincides with today's research forum. Nevertheless, it's with much pride that I welcome all of you, our contest participants, mentors, trainees, and esteemed panel of judges. Special hello to Sir Donnie Magno, our IM senior. To those familiar with the local IM handbook, IM Platinum, si Sir Donnie was actually, in my opinion, was the first to have an output similar to that. So parang precursor to the IM Platinum, I would say. We called it Mag Notes. These were a collection of his clinical pearls in IM, which helped us get through clinics in residency and internship. So this is just a sample of how esteemed our judges are for today. And again, welcome to ITRMC's 31st annual original research paper forum. Just a few words of reflection. As we appear to be seeing signs of an ending pandemic, one can't help but take stock of the past 2 years we spent with COVID, a time when the impact of research was really felt. Simply put, research was the process through which we weaved our way through the pandemic collectively as human beings. And it was instrumental with coming up with solutions to the pandemic, from medications to vaccinations to how to diagnose to policy writing, even, all of which would have been impossible without the rigors of research. Which is why it remains vital for all medical trainees to be knowledgeable about the rigors of qualitative research, not just to gain an appreciation of its fundamental role in medicine, but also to develop characteristics of integrity and discipline, and even teamwork, which are bound to be developed when one undertakes the conduct of an original research. The papers to be presented today are testament to how vibrant the research atmosphere of ITRMC has become over the years, and seeing how the research unit evolved from a one-man designation, one-man show, to now a well-staffed, well-equipped unit, complete with its own office. I cannot help but be proud and grateful at the same time, especially to our current Medical Center Chief, Dr. Ed Badua, and our present boss at Petro, Dr. Jerry Tolentino, and our past Petro bosses as well. And of course to Dr. Bervin De Guzman, Medical Division Training Officer, and to everyone really who served as facilitators to the development of the unit. Maraming salamat po. So, welcome once again. Good luck to all contest participants and mentors. I know you'll all be holding your breath until the final judgment. And I hope we all enjoy and learn much from this forum.
Thank you for the wonderful welcome, Dr. Corpus. Indeed, it was the fruit of hundreds of hours of research by thousands of people from across many varying fields that have led us through the worst of the pandemic.
And it's this research that will continue to see us through until the pandemic is officially declared to have come to an end.
Of course, a contest is nothing if it isn't bound by a set of rules by which contestants operate. To give us the criteria of judging for today's original studies, here's Dr. Marie Angeline Casino, Assistant Chair for Information Management.
Good morning. Here are the criteria for judging for original studies and oral presentation. For the original studies manuscript or written report paper, an interesting or catchy title, 2 points. A title that conveys the main idea of the paper, for 2 points. Statement of objectives, clarity of purpose, 2 points, and relevance, for 4 points. Review of literature, extensive or comprehensive review of both local and international published or unpublished data, 10 points. Proper citations, 5 points. Significance of paper. Does the paper fulfill any of the following? New information, update of old information, new perspective on published literature, novel diagnostic core treatment, addresses public health issues, addresses local medical practices, addresses quality of care issues, local disease prevalence or incidence, and meta-analysis or systematic review for 10 points. Methodology: appropriate sampling and design, 5 points. Appropriate statistical tools, 5 points. Reproducibility, 5 points. Results and interpretation of data: appropriate use of tables, charts, and figures, 8 points. Correct statistical analysis, 7 points. Discussion: correlation with similar studies, 5 points. Key issues addressed including unexpected findings, 5 points. Emphasized new and important aspects of the study in the context of current relevant evidence, 5 points. Conclusion and recommendations: link to objectives, 5 points. Balanced conclusions, 3 points. Appropriate recommendations, 5 points. And limitations stated, 2 points. Format: conformity to basic guidelines for formatting, 5 points. Criteria for judging for oral presentation: audiovisual aids, effective and interesting content, 10 points. Clear and readable text, 5 points. Appropriate use of animations and transitions, 5 points. And clear audio and timed with the visual presentation, 5 points. Presentation: clarity of voice, 5 points. Correct grammar and pronunciation, 5 points. Appropriate medical vocabulary, 5 points. Organization and structuring, 10 points. Adherence to time limit, 5 points. And ability to hold attention, 5 points. Knowledge of the case: calmness and confidence in answering questions, 10 points. Accurate and sound logic, 10 points. Critical thinking and presence of mind, 15 points. And clear flow of thought or spontaneity, 5 points.
Contestants can garner a maximum of 100 points each for the manuscript and the oral presentation. Of those, the manuscript comprises 60% of the total score, and the oral presentation comprises the other 40%.
Thank you, Dr. Casino. Of course, the criteria for judging is also essential as the guideline by which our panel of judges will determine the outcome of this contest.
This year, we are fortunate that a very distinguished group of experts have accepted our invitation to make up our board of judges.
To introduce these prominent individuals, we have Dr. Mark Jerome Mauricio, the Assistant Chair for the Committee on Research Integrity.
Good morning, fellow doctors and guests. It is an honor and a privilege to introduce to you the distinguished individuals who will make up the Board of Judges for this year's Research Forum. First on our board is Ms. Irene Abigail Guerrero. She earned her degree in film and audiovisual communication and master's degree in development communication from the University of the Philippines Open University in Los Baños, Laguna. She pursued her doctorate in communication in the same institution where she was top graduate of her class in 2019. During the pandemic, her team developed the Rapid Pass pH verification system and the Frontliner Logistics Assistance Gateway. Ms. Guerrero was also the research coordinator and program chair of the Bachelor of Arts Communication program of St. Paul College of Ilocos Sur. Currently, she is an assistant professor at the University of Northern Philippines, language editor of the Asian Journal of Education and Human Development, and coordinator of its research development and strategic communication. Our second judge, Dr. Irene Bandong, earned her medical degree from the Manila Central University and her master's degree in science and clinical epidemiology from the University of the Philippines. She is a fellow of the Philippine Board of Radiology, Ultrasound Society of the Philippines, Diagnostic Breast Imaging Society of the Philippines, and Philippine Society of Nuclear Medicine. Currently, she is the head of the Publication Committee and Research Coordinator of the Clinical Trial and Research Division of the Philippine Heart Center. Dr. Bandong is also the head of the Research Committee Group and Training Officer of the Department of Nuclear Medicine and PET City Center, as well as a member of the Research Committee Group of the Institute of Radiology at St. Luke's Medical Center, Quezon City. She was also head of the Molecular Breast Imaging Section of the Asian Breast Center, Centuria Medical Makati. Also an academician, she is an assistant professor of the Department of Radiology at the Chinese General Hospital and of the Department of Nuclear Medicine at the St. Luke's Medical Center, College of Medicine, William Quasham Memorial. She is a distinguished lecturer in various conventions in her field of nuclear medicine and radiology. She has authored and presented many researches both locally and internationally, notably in the European Society of Radiology Congress and in the International Conference on Integrated Medical Imaging in Cardiovascular Diseases in Vienna, Austria. Finally, the chairman of our Board of Judges, Dr. Jose Donato Magno. He is a fellow of the Philippine College of Cardiology, Philippine Society of Echocardiography, and the Foundation for the Advancement of Surgical Education. He is also a fellow of the American Society of Echocardiography, a member of the European Society of Cardiology, and the ASEAN Society of Echocardiography. He serves as the president of the Philippine Society of Echocardiography Incorporated. Dr. Magno is the executive director and concurrent cardiology chief of the Cardiovascular Institute, Angeles University Foundation Medical Center, and section head and director for training of adult echocardiography in the University of the Philippines, Philippine General Hospital. He is also a clinical associate professor in the University of the Philippines College of Medicine. Dr. Magno is the senior reviewer for the European Heart Journal Case Reports and is a peer reviewer for Circulation CV Imaging, the International Journal of Cardiology, the Journal of the American Heart Association, the Acta Medica Filipina, the Philippine Journal of Cardiology, and the Philippine Journal of Internal Medicine. We have quite a panel this year for our distinguished Board of Judges. Thank you for taking the time to join us today and for taking on the difficult task of judging today's contest. To all of our presenters today, good luck and do your best.
And there you have it, our distinguished panel of judges.
With all the preliminaries done, there is nothing left but for us to commence the contest paper proper.
The presenters are given a maximum of 8 minutes to present their studies and will be given a maximum of 7 minutes to answer the judges' questions.
And countless hours, tiring study, hard work, and Jude studies.
First up is Dr. Odani Gemma Francis Marconi, with her study entitled Correlation of Cerebrospinal Fluid Density with the Severity and Clinical Outcome of Traumatic Brain Injury in Recent Head Trauma Patients in ITRMC.
Good morning, doctors. I am Dr. Odani Gemma Francis Marconi from the Department of Radiology. I will be presenting today my research paper entitled Correlation of Cerebrospinal Fluid Density with the Severity and Clinical Outcomes of Traumatic Brain Injury in Recent Head Trauma Patients in the Locus Training and Regional Medical Center. Traumatic brain injury is a non-degenerative, non-congenital insult to the brain from an external mechanical force, possibly leading to permanent or temporary impairment of cognitive, physical, and psychosocial functions. In a 2019 study, the incidence in Southeast Asia was 45,349, with a prevalence of more than 1 million, while in the Philippines, the incidence was more than 7,000, with a prevalence of more than 204,000 cases. This is the overview of what will be discussed. The general objective of this study is to determine if there is significant correlation between CSF density measured on non-contrast cranial CT scan and severity and clinical outcomes of patients who sustained recent head trauma. For the specific objectives, first objective is to determine if there is increase in the CSF density measured on non-contrast cranial CT scan among patients who sustained recent head trauma. Second is to determine the correlation between CSF density and severity of traumatic brain injury as assessed by GCS on admission. And third is to determine the correlation between the CSF density and clinical outcomes of patients who sustained recent head trauma. This study employed a cross-sectional retrospective study design. The study population consisted of 361 patients who sustained recent head trauma from January 2018 to December 2018. The data were gathered through patients' medical records, and patients with cranial tumors, CNS infection, or other intracranial lesions that may cause disruption of the blood-brain barrier were excluded. For the sample size calculation, the Cochrane's formula was used with 50% response distribution. All scans were done in 16-slice CT scan machine. The CT scans were evaluated based on the measurements of CSF density in both lateral ventricles with an area of 1 square millimeter in 4 different locations, which were rated by 2 independent radiologists. Coding was done for data gathering and were assigned to computerized records or documents. These are examples of 2 different cranial CT scans with measurement of the CSF density within 4 locations in both lateral ventricles. An abnormal CSF density means more than 10 Hounsfield units. The data gathered were tabulated, analyzed, and computed statistically using statistical package for social sciences version 22. Frequency count and percentage were used to express categorical variables. Pearson correlation coefficient was used to determine if there is significant relationship between CSF density and severity of TBI assessed by GCS. Chi-square test for independence was used to determine if there is a significant difference in the CSF densities among recent head trauma patients with normal and abnormal CT scan findings and clinical outcomes. A p-value of less than or equal to 0.05 is considered statistically significant. A total of 361 patients were included in the study. Majority of the patients are male. Vehicular accident is common. Most of the patients have normal CT scan findings, with the majority still having a normal CSF density. The increased CSF density comprised of 23%. The severity of traumatic brain injury is measured using GCS, which is mostly mild, although 12.7% is moderate and 8.9% is severe. Many patients have been discharged, though admissions and surgery have to be performed, and death at 6.4% have to be given attention. Table 2 shows increase in CSF density, and applying the Mann-Whitney-U test with a p-value of 0.000, the results show that the increase in CSF density among 83 patients was significant. Using the one-sample Kolmogorov-Smirnov test, the result shows a p-value of 0.000, thus the increase in the CSF is significant. This validates other studies of Sosin DM et al., which indicates that traumatic cerebrospinal leakage is a complication seen in 2% of all head-injured patients and in 12 to 30% of cases of basilar skull fractures in CT scan findings. A chi-square test of independence was performed and the relation was significant, and therefore patients with abnormal CT scan findings are related with increased CSF density in patients with traumatic brain injury. Table 3 shows correlation of CSF density and severity of TBI using the person-product moment correlation. A correlation coefficient were obtained and that there is a significant negative moderate relationship between CSF and GCS. This means that the higher the CSF density corresponds to poorer GCS status. This research finding corroborates other literature by Moch C.A. et al., wherein the initial GCS scores will be inversely associated with GCS density after severe traumatic brain injury. For the clinical outcomes, there is a significant correlation between CSF and the clinical outcomes of patients who sustained head trauma, and that increased or abnormal CSF density was predominantly found in patients who were admitted and subsequently received surgical intervention and those who died. This is supported by previous studies done by J.S. et al., wherein CSF leak is a complication in approximately 1 to 3% of TBI cases and is typically associated with the basilar skull fracture. So for our conclusions, there is a significant increase in CSF density measured on non-contrast cranial CT scan among patients who sustained recent head trauma with evident abnormal findings. Second is that an increase in CSF density correlates with the severity of head trauma, such that increased CSF density was observed in those with poorer or severe GCS status. The last but not the least, there is significant correlation between CSF density and clinical outcomes of patients who sustained recent head trauma. Increased CSF density was predominantly found in those who were admitted and subsequently received surgical intervention and those who died. For the recommendation, CSF density measurement on CT scan may serve as potential early biomarkers. It could potentially be used to identify patients at risk, hence can be adopted to be part of the CT scan protocol. The aforementioned can be also a guideline on the management and care of TBI patients. Finally, the patients and the patient's family and care providers should be educated about what to watch, for that may suggest the need for re-evaluation because of recurrence or complications from any of the interventions. That ends my presentation. Thank you very much.
Thank you, Dr. Marconi. We shall now proceed to the Q&A portion. The judges will throw their questions in this order. Number 1 is Dr. Magno, followed by Dr. Bandong, and then number 3, Dr. Guerrero.
Hello, good morning. Yes, congratulations to the team for this nice research output. I just have a few questions. Why did you not mention acute demyelinating and autoimmune conditions or spinal neoplasms in your exclusion criteria? Wouldn't they affect the consistency of your intraspinal fluid? Maybe you can answer that first question.
Good morning, doctor. I guess it is part of the exclusion criteria wherein I said in my report, in my presentation that it it falls on the other intracranial lesions that may cause disruption of the blood-brain barrier. It also includes those cases wherein, like you said, doctor, the demyelinating lesions that would affect the CSF also.
Yeah, I agree. It might be encompassed, but I guess if you were to refine the manuscript, it would be advisable to specify these conditions because not all of these are intracranial lesions. Specifically, spinal conditions and tumors they might affect. The next question, you said that there were two radiologists who read the scans and they read them independently. What happens if the readings are contradicting? Who resolves the issue?
In the with the gathering of data, doctor, we don't have any problem with the measurements. Almost all of the measurements were coinciding with each other, doc.
Right. I guess that's fortunate, but I think for the purposes of really being meticulous, if someone was to replicate the study, you would have some provision for discordance in reading. In that case, I would recommend maybe a third reader to break the tie. So you have to put here a provision in the setting of discordant readings. How will it be resolved? That's it, basically. Thank you.
Thank you, doc.
Good good morning. My congratulations to your paper. Congratulations. Would like to ask my first question is, what is the rationale of using 50% response distribution for the sample size? And my next question is, were you able, do you have an in-house statistician? And my next other question is, do you have a mean cutoff of the CSF density, Hounsfield mean, for each type of Glasgow score, your classification Glasgow score, and your clinical outcomes? Do you have mean standard deviation for the CSF Hounsfield mean? Did you understand my question?
Sorry po, doc. Can you repeat the questions po?
The first question is your sample size. You use the 50% response distribution. What is that? Why did you use that 50% value as against to like an article that will say that a certain standard deviation of Hounsfield unit would predict or would define that this is abnormal, or this would cause this correlates with the CS abnormal clinical outcome. And my next question is, do you have in-house statistician, and were you able to get mean cutoff for each GCS category and your clinical outcome?
Thank you, doctor. So for the first question po, we use the 50% response distribution to for us to enable to get the right sample size, right computation for the sample size. And for the second question po, is it more of the significant doc? Kindly repeat the second question po, doc. Medyo mahina po ang audio.
Do you have an in-house statistician? In-house.
Yes po, Doc. We have
Statistician.
in-house
Yes.
statistician
Oh,
here in ITRMC po.
okay. Oo. Hindi ka ba nagtanong ng cut-off for the particular GCS category at saka sa clinical outcome? Kasi ang piniset mo lang is the abnormal CSF value. At saka hindi ba nag-advise yung statistician nyo to present your data in a more yung table, not kasi yung presentation mo on the outputs are the outputs of the software. So dapat ang presentation mo is naka-table na yun. Siguro in the next time you would in retrospect I suggest that you use the sample size because respondent is different. Your response distribution is you usually use this if you have a questionnaire. And your case is it's a clinical case. So you have to compute the sample size. It will be based on your outcome. So your outcome would be the change in clinical outcome of either yung mortality or survival, or what is the cutoff or standard deviation of the Hounsfield unit for that. Then you have to compute the sample size based on that. Parang may odds ratio. Okay. And yun. That's all.
Thank you po, Doc. Noted po, Doc. For regarding the cut-off, Doc, I didn't ask for the cut-off from the statistician. Wala po kaming inano po dyan. But noted po, Doc, for the next study.
Can I ask another question? Is it okay? Okay. So the two radiologists reviewed the CT scan. So what image did you present? Only the area of the lateral ventricles at the level of the base of ganglia? Yun lang ba yung lahat ng in-evaluate? Or were the radiologists able to see all the images of the brain?
We only use the image at the level of the basal ganglia po, Doc.
Yes, very good. Because they will be blinded. So yun, okay.
Yes.
Very good. Okay. That's all. Thank you. Congratulations.
Good morning, everybody. Good morning, Dr. Marconi, and congratulations for this study. Okay, for my question, although I'm coming from a communication point of view for the lens that I'm using, basically you already said this in your results as part of the recommendation. But in general, I would like to ask, how will your findings contribute to treating patients with TBI in not just in La Union, but its applicability, its usability within the country? Thank you.
Thank you, Professor, for that question. With the increasing trend kasi here in the province of La Union, we have increasing trends of traumatic brain injuries at the ER. So with that and with the present situation here in La Union, our hospital is presently being developed to become the referral center for trauma cases in the region. So with that vision and mission of the hospital, trauma-related researchers are being encouraged, and which paved the way for us to conceptualize this planned research, which entitles correlation of CSF density with the severity and outcomes of brain injury.
All right, thank you. Thank you, Dr. Marconi, and congratulations.
Thank you po, Doc.
Marconi, and thank you, judges. Thank you, Dr. Marconi, and thank you, judges. Let's move on to our second entry entitled osteosynthesis of metacarpal and phalangeal fractures using interlocked K-wire technique, followed by immediate mobilization, a pilot study. Let us welcome Dr. Modesto Bolislis.
The use of K-wires for fixation of metacarpal and phalangeal fractures is a well-established technique. These are inexpensive, readily available, and can be inserted percutaneously. The wires can also be removed in an outpatient setting, removing the need for another hospital admission. K-wires carry its own disadvantages. They may lose, back out, or break, leading to a loss of reduction and eventually to malunion or non-union. It has low resistance to bending loads. That's why it has to be supplemented in a form of a splint. This prevents early mobilization of the affected and adjacent digits, which might eventually lead to joint stiffness, prolonged rehabilitation, and return to function. So the question is, if the fixation construct will be modified, making it into a triangle by interlocking them, is this stable to permit early mobilization and will have good outcomes? Since in the field of engineering and architecture, the triangle is considered as the most stable 2D structure. Good day. I am Dr. Modesto David A. Bolislis, and I am presenting to you my research study entitled Osteosynthesis of Metacarpal and Phalangeal Fractures using Interlock K-wire Technique, followed by immediate mobilization. Here are my objectives. Can the patients have good outcomes if we interlock the wires and allow early mobilization? As to my specific objectives, we will observe for the following. Loss of fixation as evidenced by wire loosening, breakage, or backing out prior to removal. Fracture union as evidenced by absence of pain and motion on the fracture site, with or without callus formation on X-ray. Malunion as evidenced by a deformity on the fracture site when unacceptable angulations of X-ray. Non-union as evidenced by presence of pain and motion at the fracture site without callus formation on X-ray. And lastly, pain during range of motion of digits as graded using visual analog scale. This is a pilot study with a minimum recommended sample size of 12. Purposive sampling was used within 1 year of data collection. Here are my inclusion and exclusion criteria. Eligibility was determined by the primary investigator together with 2 residents. An informed consent will be signed prior to scheduling. The technique was performed by the primary investigator together with 2 residents. Reduction and fixation were done using 2 K-wires. The exposed ends of the K-wires were bent and crimped to each other. A passive ROM of the affected digit was done to confirm stability, ensuring that there is no impediment to early mobilization. Thin dressing was applied on the K-wire insertion site and a neutral volar splint was applied. After 48 hours, the splint was removed and all patients were referred to PT rehab for range of motion exercises. The outcomes were evaluated by the principal investigator together with 2 residents. There were 2 follow-up periods and were evaluated for the following. A total of 22 fractures were evaluated. All are males with a mean age of 35.8 years. In terms of fracture type, 45% were closed fractures and 55% were open. When it comes to hand dominance, 91% were right-handed and 68% of fractures involved the left hand. It was noted that in 77% of our sample population, the injuries occurred on their non-dominant hand. The common mechanisms of injury were vehicular accident and an occupation-related crushing injury. The proximal phalanx was the most commonly fractured bone. Loss of fixation was noted in 1 out of the 22 fractures fixed, same as true with the non-union. They were noted to be open fractures that occurred in the small finger and its associated metacarpal. No fractures went into malunion. We observed pain during range of motion in 18%, and these cases were the following. It was noted that these cases were intra-articular fractures. No pain was reported on the joints of the other digits. They reported that oral analgesics provided pain relief, and the pain does not interfere with their hand function. Fixation of hand fractures using K-wires is a common technique. Although not ideal for some fracture configurations, the advantages, availability, and cost-effectiveness make it a common fixation device in our setting. The gender and mean age in our study were similar to the reviewed literature. Same as true with the proximal phalanx as the most commonly fractured bone, and vehicular accident as the mechanism of injury. Our findings of left hand involvement and an open fracture type were in contrary to the reviewed literature. The technique we performed was identical to the one did by Farias and colleagues, and in their study, they achieved fracture union in 96.4% of their population, almost similar to our study, with 95% fracture union rate in 22 cases. Shalom reported the following complications of KMR fixation, with pin loosening being the most commonly observed due to poor pin placement not recognized. Shu and colleagues also recorded the same complication and reported 2 cases each of malunion and non-union. In our study where we noted 1 case of non-union, the patient was offered bone grafting and possible arthrodesis. However, this patient refused further treatment and stated that the outcome does not interfere with his work activity. We did not attribute the non-union to the performance of the technique, but rather to its open fracture type. Farias also recorded loosening of wires in 10% of his population. This was due to accidental snagging of wires, non-compliance with the regimen, and seizure episodes. In our study where we noted 1 loss of fixation, we attributed it to the following factors: open fracture, the contribution of the small finger when performing grip, the multiple K-wire insertion attempts, and the protruded interlock wires hooking during change of clothes. Also in his study, stiffness of the joint was reported in 4%, requiring more aggressive therapy and eventually surgical intervention. In our study, the joint stiffness was already prevented since we were able to permit early mobilization. But we observed pain on the joint near the fracture site relieved by oral analgesics. We did not attribute the pain to the fixation technique, but rather to the intra-articular nature of the fracture. The challenges that we encountered during the performance of the technique was that adjacent structures had to be considered before interlocking the wires, as this may impede mobilization of other digits. Careful bending of the wires must be observed in order to prevent loss of reduction and fixation. Removal of the wires posed some sort of difficulty since we have to loosen the crimped wire ends prior to removal. The weaknesses that we identified were the small sample size and a short follow-up period. We encountered a decrease in number of cases due to COVID-19 pandemic. The follow-up period was shortened due to difficult transportation and temporary closure of our outpatient department. In conclusion, the technique provided a stable fixation to permit early mobilization of the affected and adjacent digits and had good outcomes. The technique was applied mostly to isolated single fractures with simple configuration. A larger sample size, longer follow-up period, and a comparator group would be our recommendations for further research studies. Here are my references. Thank you.
Thank you, Dr. Thank you, Dr. Bulislis. Now, Dr. Bandong, Dr. Guerrero, and then Dr. Magno will ask their questions.
Good morning and congratulations. My first question is, what is your study design and how did you compute for your sample size?
Thank you, Mom. So my study design, this is a pilot study, and then I looked into journals on what is the recommended minimum sample size on how to conduct such pilot study. So I was able to look into a paper by Moore and colleagues in which they stated that the minimum sample size for such pilot studies would be 12. So their rationale for having a minimum sample size of 12 per group in conduction of a pilot study is that this group conducted in a pilot study will be used as a baseline in further conduction of the intervention using a larger sample size.
Regarding the study design, the type of study design is descriptive, cross-sectional, case-centered, randomized control trial. So what type of study design is your paper?
This is a descriptive study design.
Okay, very good. Descriptive. So how long is the follow-up for this patient?
The last follow-up of our patients, po, Doctor, is at 12th week po, post-operative. So that's 12th week. So 3 months.
So you evaluate the findings based on the symptoms and radiologic findings. Is that?
Yes po, Doctor. Yes po.
Okay, that's all. Thank you.
Thank you po.
Hi, good morning.
Good morning po,
Dr.
Doctor.
Modesto. Ayan. Congratulations for this study. For my question, I'd just like to ask, are there any other existing KWAR techniques being studied or practiced here in the country that you know of?
There is up until present po, there is no other technique aside from the modification that we did that is being performed locally.
Okay. You mentioned that the methodology used was descriptive.
Yes po.
Based from the pool of your 22, tama ba? 22 respondents,
Yes.
was there any significant finding that's deviant from all the rest?
In terms of significant findings, there were two patients who had a multiple fracture, meaning there are more than one fracture that occurred in their hand, but the majority they are isolated and only single fractures.
Okay. The reason why I'm asking, I'm more into qualitative research studies, and it would be better if in your manuscript you also highlight more or less their experiences based on the healing process and even the procedure that you performed on them, for this to be because your research is basically unique here in our country. For those specific unique findings to be highlighted in your research, that way, if more research like this would prosper, the 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 opportunity for citation as well to have your study as a framework for future research will be more so established. Again, thank you. Thank you.
Noted po. Thank you.
Hi, Dr. Bolislis. Thank you to you and your team for this investigative effort. A few
Thank you po,
comments
sir.
and questions. My first comment is for someone who is not well versed in orthopedics. I think it would be hard to understand the paper at the get-go if you bombard us with technical terms. So maybe to refine your manuscript, you might want to start the introduction by first discussing hand fractures from a general standpoint. And then you follow it up by mentioning what is the data about clinical burden of disease and how is it important to explore these strategies for fixation. Okay. Now,
Thank you,
in
po.
your objectives, wouldn't it be better to mention stability as an outcome? And then you specify that stability is measured by determining loss of fixation?
Actually, sir, that would be more acceptable, sir, because what I want really to assess is the stability of the
Right,
fixation,
right.
whether this is stable enough to permit early mobilization.
So that can actually be mentioned in the general objective, and then you specify it in greater detail in the succeeding segments. Now, you mentioned something about loosening of wires, so I'm not well versed here. Is this based on purely subjective assessment, and who performs this technique, and will this not be prone to variability?
Okay. I perform the technique po, sir, and then when the loosening of wires, this is assessed by the principal investigator, and I also have a junior resident assess if the wires are really loose. When we say loose, doctor, we can easily twist and then remove the wire even without the use of an instrument. So in order to further in order for us to further agree if these are really loose, so we have to consult one of our senior residents. So it will be evaluated by 3 residents if the wires are really loosened prior to removal.
Right. But is there not a specific step-by-step process that you should follow to assess loosening? Because for all we know, some investigator might do it a different way. Is there a protocol for checking loosening?
So we check for loosening by gently twisting the protruded wire ends.
Yeah, but even gentle twisting can be very subjective. Like, do you say that you make a few rotations and all these things, or is it really very subjective?
It is subjective.
Very subjective. So maybe that's one of the limitations of the study.
Yeah.
My last comment is about exclusion criteria. I did not see you make a comment on patients with congenital digital malformations or those with malignancies. Aren't these patients also prone to bone microfractures?
Yes, sir. For those pediatric patients, we can also use a K-wire for correction of their deformity. However, sir, the disadvantage of using the wires is that we might be able to hit the physis muscle or the growth plate. So if we are able to hit that, it might result to a growth arrest. So it will result in a finger growth arrest.
Right. In any case, my point there was maybe you could consider adding these subsets in your exclusion criteria because that might affect the outcome. All right,
yes,
that's it.
Noted.
Congratulations.
Thank you, Doctor.
Thank you, Dr. Bolislis and our judges. Our next presenter is Dr. Vivian Abitong. Her study is entitled Prevalence of Nutritionally at-Risk Elective General Surgery Patients in a Tertiary Government Hospital in La Union from November 2020 to July 2021.
Nutrition is a basic requirement of life. It plays an important role in promoting health and preventing disease. Good morning, doctors. I am Vivian Abitong from the Department of Surgery, and I am presenting my research entitled Prevalence of Nutritionally at-Risk Elective General Surgery Patients in a Tertiary Hospital in La Union from November 2020 to July 2021. The prevalence of malnutrition among hospitalized patients is high, often underdiagnosed, which significantly increases morbidity, mortality, length of hospital stay, and readmissions. Reports on prevalence of malnutrition in our institution, particularly in our department, are lacking. This study was intended to answer the following. This is my general objective, and these are my specific objectives. A cross-sectional descriptive study design was used. This study involved all elective general surgery inpatients from November 2020 to July 2021 with these inclusion criteria. The sample size was determined using a web-based statistical calculator and the use of purposive sampling in the selection of subjects. A total of 148 respondents were included in the study. Before the conduct of the study, approval was obtained from the Research and Ethics Committee of the institution. All patients who satisfy the inclusion criteria were included in the population. A written informed consent was obtained. The history taking and physical examination was done, and the record was attached to the patient's chart. The nutrition risk screening form from the Philippine Society of General Surgeons surgical nutrition files was used and filled out by the researcher to determine nutritional risk. The nutritional assessment and risk level form was filled out only if the respondent was nutritionally at risk. Outcome was determined and graded using the Clavin-Dindos classification of post-operative complications. The data gathered from the respondents were collected, tabulated, and interpreted using frequency count and percentage. The figure shows that 59% of the respondents are nutritionally at risk. The following reflect the clinical demographics of the group. It showed that most of the respondents are aged 41 to 50, mostly female and have normal BMI. Most surgical procedures were breast surgeries. Most of them denied having comorbidities, are college graduate and earns less than 100,000 yearly. And most had good outcome. The data gathered were interpreted and analyzed by a statistician using chi-square test and ANOVA. It can be deduced from here that there is a significant statistical correlation between nutritional risk and type of surgery, body mass index, and surgical outcome. Many patients are already undernourished before reaching the hospital. At least 1 in 3 people are malnourished on admission, hence are at increased risk of developing post-operative complications and is a poor indicator of post-operative outcomes for decades. Sustainably improving nutrition remains one of the greatest global health challenges despite the worldwide efforts to end all forms of malnutrition. Perioperative surgical nutritional enhancement is still a common, largely unrecognized challenge in our setting. Severe malnutrition has been reported in 42% of patients admitted in several government hospitals in Manila. The increasing trend in nutritional risk as the age increases may be due to the effects of aging. Starvation can be one cause of malnutrition in the surgical patient. During the post-operative period, the patient is in a metabolic stress. The release of stress hormones and mediators contribute to an increase of gluconeogenesis, proteolysis, and resting energy expenditure, resulting to insulin resistance, glucose intolerance, loss of adaptive ketogenesis, and the breakdown of muscle protein. Surgical aggression also generates inflammatory response, causing changes in the concentration of acute phase serum proteins, which worsens intermediary metabolism and can lead to hypermetabolic state. This research concludes that 59% of patients undergoing elective general surgical procedures in ITRMC are nutritionally at risk. Poor outcomes are expected in a malnourished cancer patient undergoing major elective surgery. Surgical outcomes are affected by nutritional risk of patients. The research was limited to elective general surgery procedures and was done during the pandemic when elective surgeries were limited. The findings in this study may be used to strengthen or restructure existing programs and policies in our institution. We recommend that the physicians continue doing the nutritional screening and assessment of elective patients in an OPD basis, and that the screening and assessment be a part of the preoperative preparation, aside from the routine workup and clearance. It is of utmost importance to identify high-risk groups. Once identified, we recommend collaboration with the dietary service for nutritional build-up, preferably using oral nutritional support. Once the patient is prepared for operation, we recommend that the patient visit the nutrition clinic as part of the ERAS protocol. Lastly, baseline nutritional data in our institution is lacking. This study, the first in our institution, can provide a useful springboard and may serve as a useful tool to guide future institutional protocols or policies and serve as a basis for further studies. Thank you so much for listening.
Thank you, Dr. Abito and our three judges for that presentation. Maybe call on our three judges for to comment, Dr. Guerrero, Dr. Magno, and Dr. Bandung.
Hi, good morning again. So congratulations, Dr. Abitong, for this study. Actually, all my questions, initial questions were already answered with your presentation. I just want to make a recommendation. The study implies the prevalence of poverty. So maybe include as part of your recommendation to provide grassroots recommendations specific to LGU in La Union, as data is significant already in implying poverty within the area. So part of our you mentioned in your slides that um, nutritional and screening assessment should be done continuously. However, these are more or less connect or concentrated in-house within your organization um, to give more ano ba, purpose in the study, because the study is really giving us alarming data, and also in your implications presented, parang there's a need already to realign our general services with communities. So maybe form linkages with other agencies so that your study will have a more purposive scope. Yun lang. Congratulations again. Thank you.
Morning po, ma'am. Good morning po, doctors. Yes po, noted po ito, ma'am. Thank you po.
Hi, Dr. Abitong, Dr. Mago here.
Morning,
Thank
sir.
you to your group. I think this is a very important investigative piece. I would like to clarify again, what's the difference between someone who is malnourished and someone who is nutritionally at risk?
Actually, sir, there is no difference naman po in a patient or in a person who is malnourished and who is nutritionally at risk. Once a patient is malnourished, sir, they are almost automatically regarded as nutritionally at risk, sir.
So you're saying you cannot have someone who is nutritionally at risk but is not malnourished?
Opo, sir. Yes, sir.
I'm quite confused because malnutrition is the condition, and when you say you're at risk of a condition, means you don't have that condition yet. So how do you now distinguish the two if any distinction exists at all?
Malnutrition, sir, is a condition wherein there is a lack of, for example, protein or calories, sir, such as kwashiorkor um,
And there's an objective way to quantify malnutrition, right? So how do
Yes,
we
sir.
now know if a patient, a surgical patient, is nutritionally at risk?
Based on my on the guidelines, sir, on my form, on the form that I used, a patient is considered nutritionally at risk if his or her BMI is less than 18.5 or more than 30, and if there is a weight loss during the past months, sir.
All right. Okay. And then there's a few comments about your manuscript and your statistics. What was your assumed P or prevalence when you tried to compute the sample size?
Wala po, sir.
No assumed P or prevalence?
Sorry, P value, sir.
No, meaning the prevalence. Because if you're gonna compute the sample size, you need background data on what is the assumed prevalence of a particular disease entity that you're looking into, right?
Yes,
So
sir.
if this disease entity is pretty rare, then you're gonna need a smaller sample. But if it is quite prevalent, then you will need a bigger sample.
Sir, noted po, sir. But based on my reading, sir, the prevalence of malnutrition is about 42%, but is limited in Metro Manila po. The studies were limited in Metro Manila.
So was this the number that your statistician used to plug into that formula for sample size calculation?
The statistician used just the number of elective patients po, sir, during the time period. It was based on the number of elective surgeries.
All right. That last question for you. Let's say you determine that a patient for elective surgery is nutritionally at risk. How will that change the management of the attending physician?
If the patient is nutritionally at risk, sir, we will first refer the patient to the nutrition clinic, sir, for build up po. And then for at least 7 to 10 days of nutritional build up, we will reschedule this patient for elective surgery, sir.
Right. Just thought of another question, again, back to the exclusion criteria. Are there certain subsets of patients who will undergo surgery that will automatically be at risk of malnutrition? Let's say this patient has some GI lesion. Wouldn't that put the patient at greater risk than someone who will undergo maybe breast surgery?
Yes, sir. For example, sir, the cancer patients, sir, are expected to be nutritionally at risk already upon admission, sir.
So maybe if you're going to do a succeeding study, you might want to consider doing some subgroup analysis of these subsets. That's it. Thank you.
Thank you po, sir.
Good morning and congratulations. My first question is, what are your clinical outcomes? Clinical outcomes.
Sorry, ma'am. Thank you po. For the clinical outcomes, ma'am, I was guided by the Clavien-Lindo classification for post-operative complications as a guide for determining the clinical outcomes, ma'am. And most of the patients.
What are the results?
Most of the patients. Yes, ma'am. Most of the patients are Clavien-Lindo classification 1 po, ma'am. So meaning they have a good outcome po.
Just a comment regarding your manuscript. Would like to suggest that you also request your in-house statistician to help you in putting up the table. And in presentation, if you have numbers, you should present it in numbers, not on graph.
Noted po, ma'am. Thank you po.
And the rule of thumb is if you have one business objective for one table.
Noted po, ma'am. Thank you po.
And those were our first 3 contestants. Already, I'm beginning to see how difficult it will be for our judges to choose a winner.
But before we continue with our next set of paper presentations, let's pause for a moment as we listen to a message of encouragement and inspiration from our Medical Center Chief, Dr. Eduardo Badua III.
On behalf of the Ilocos Training and Regional Medical Center, it is my privilege to extend our warmest greetings and congratulations to all participants of the 2022 Annual Research Forum. Let me express my appreciation of the effort and dedication of the members of the Hospital Research Unit headed by Dr. Alan Porpus for anchoring firm on the hospital's research agenda. Congratulations to our Ethics Review Board headed by Dr. Amy Sanchez for their accreditation. Let me reiterate that research is one of the mandates of ITRMC aside from service and training. We give credit and gratitude to all the pioneering and devoted staff and the committees handling technical and editorial reviews, information system, research integrity, and publications. As one member institutions of the Region 1 Health Research and Development Consortium, ITRMC is active in health research activities. And as a research facility, we aim for well-structured and sustainable culture of research, not only in ITRMC, but also in the locality it serves. Therefore, this research forum is a great avenue to highlight and recognize the various research initiatives undertaken by our young colleagues. This is also one of ITRMC's concrete efforts in fulfilling our vision on becoming a people-centered, multi-specialty, apex hospital delivering quality health services, training, and research in the Ilocos region by 2025. The what is known as the Sinlag de Amiana. As most of this research were undertaken during the past few years during our battle with COVID-19, our researchers has to work doubly hard to come up with competent papers worthy of publication and presentation. After all, like the scholars Luther and Kichetti quoted, resilience research has substantial potential to guide the development of effective interventions for diverse at-risk population, to forces that are protective in nature as well as to those that exacerbate vulnerability and to the mechanisms that underlie their effects. As research and development are set to play a vital role in developing science-based technologies and innovations toward safe and healthy communities through the medical field, we look forward to the success of this endeavor, and that we wish all the presenters the best for this year's annual research forum. Thank you, stay safe, at mabuhay po tayong lahat.
Thank you for your encouraging words, Dr. Badwa, and we all look forward to participating in fulfilling the vision of ITRMC's future.
And on to our second set of contestants. Next up is Dr. Navid Rodaki with a study entitled Efficacy of Oral Melatonin in Preventing Necrotizing Enterocolitis among preterm infants in a Level 3 neonatal intensive care unit in the Philippines, a double-blind randomized controlled trial.
Time is relative according to Albert Einstein's theory of relativity. It is never absolute. So what if you could look into the future? Would you fix the mistakes you're about to make? But what if I told you can actually fix a tragedy before it even happens? Would you? Good day. Necrotizing enterocolitis is one of the most common complications associated with prematurity. Its incidence is highest among those weighing less than or equal to 1,500 grams with a high mortality rate. Its pathophysiology is believed to be multifactorial, primarily of an inflammatory response in the immature gut mucosa leading to hypoxic ischemic injury and eventually cell death. Anemia, thrombocytopenia, leukopenia, and even neutropenia are seen among these patients and correlates clinically on the prognosis and progression of the disease. In relation to its pathophysiology, melatonin is one drug that could be used as a prophylactic treatment among these patients because it is a immunomodulator, it prevents oxidative stress, a free radical scavenger, and an anti-inflammatory. To date, no drug has been found to prevent NEC among these high-risk preterm newborns. With this, our primary objective was to determine the efficacy of melatonin in preventing NEC among preterm infants weighing less than or equal to 1,500 grams in a Level 3 NICU in the Philippines with the following specific objectives. This is a double-blind randomized controlled trial done in a Level 3 NICU in the Philippines which included 100 preterm infants weighing less than or equal to 1,500 grams with no other complications. Sample size was computed using G-Power version 3 with the following assumptions as shown. Randomization was done using 1:1 block scheme using the participants' pediatric age. Allocation concealment was done using sealed and opaque envelopes which was numbered according to participants' code. Intention to treat protocol was used in this study. After a qualified participant was admitted, the research assistant will explain the study and will ask both parents to sign the consent. The mother and the father can withdraw at any given point in time without prejudice in the management of the patient. The control group received 5 ml of plain breast milk. The treatment group received 2 crushed tablets of 3 mg melatonin tablets added in 5 ml plain breast milk given within the first 24 hours of life, then daily until 7 days, once a day unless contraindicated, given via cup feeding or through drip feeding. The dose was based on the study done by El Fragi and Mustafa et al. Patient's vital sign, abdominal girth, and presence of residual among those placed on OGT, vomiting, melena, and hematochezia were recorded. A baseline chest radiography, which included the abdomen, was requested at the start of the study and was repeated as deemed necessary. CBC was also monitored daily. Follow-up was either through face-to-face or online 3 to 7 days after discharge. Safety of melatonin have been well established. There have been no reported cases of melatonin overdosage among neonates. Melatonin's toxicity was studied by Barkas et al. And they failed to establish a lethal dose because at 800 mg per kilogram, it could not produce death. It is attributed to melatonin solubility because it is both a lipid and water-soluble substance. Data were coded suitable for analysis and analyzed using SPSS version 21. Shown in this slide are the baseline characteristics which was comparable at the start of the study. An independent sample t-test was done to compare the hemoglobin level, WBC count, platelet count, and ANC on the 3rd, 7th, and 14th hospital day with a p-value of less than 0.05 in favor of the melatonin group. Time to event analysis using Kaplan-Meier curve was used to determine the average number of days to cause significant change in the different blood parameters measured, as shown in this slide. No significant difference in the development of anemia between the two groups at a p-value of more than 0.05. However, a 38% reduction in development of anemia was noted. To continue, among those given melatonin, it took a mean of 12 days before the development of significant leukopenia with a 71% risk reduction. Thrombocytopenia was noted on the 11th day among those given melatonin and 7th day on the control group with a 66% risk reduction. Neutropenia was reduced by 58% among those given melatonin with a mean of 12 days before significant neutropenia was noted as compared to 8 days among the control group. Although hemoglobin, WBC, and ANC are non-specific in diagnosing NEC, their use comes in staging and therefore prognosticating the severity of NEC. Zeveri et al. Noted that among those given melatonin, there is a noted increase in the cellularity among different cell lines. Buyukavsky et al. Noted a decreased incidence of cytopenia among those treated with cyclophosphamide. Suggested mechanisms include prevention of cellular apoptosis, restoration of neutrophilic functions such as phagocytosis and degranulation, and formation of neutrophilic extracellular traps, thereby preventing neutropenia. However, studies by Cernisyov and Ren et al. Contradicts these findings. They establish that melatonin prevents granulocyte migration and adhesion, which will eventually lead to neutropenia. NEC among those given melatonin was significantly reduced by 80% with a mean of 13 days before its development versus 7 days among the control group. As NEC's etiology remains unclear, current management focuses on treating and vigilant monitoring rather than prevention. Hence, preventive strategy and possibly discovering preventive drug for NEC should be a priority. Aza et al. And Elfragi et al. Suggested the following mechanism of melatonin in preventing NEC. 1. Blocking of pathogenic T helper 17 cells. 2. Augmentation of Treg cells which suppresses immune response. 3. Activation of cyclooxygenase prostaglandin enzyme system. And 4. Suppressing oxidative stress, nitrosative stress, and mitochondrial dysfunction, which all leads to an anti-inflammatory response. Furthermore, the results showed a 68% reduction in feeding difficulties. Melatonin group was transitioned to full oral feeding faster with a mean of 5 days versus 11 days on the control group. Asa et al.'s RCT on melatonin's effect on preterm feeding showed lesser residual per OGT among the experimental group. These findings can be suggestive of melatonin's ability to prevent NEC, which can be contributory to the lesser number of days these infants were fully fed. The overall mortality was also significantly reduced, with a 58% risk reduction among the melatonin group. This may be due to melatonin's overall effect on newborn illness, as it is also determined to be effective as an adjunctive treatment for sepsis. In conclusion, this study demonstrated the efficacy of melatonin in preventing NEC among preterm infants. Its ability to prevent cytopenias, also in lowering the number of days to full feedings among participants and decrease mortality rate. We recommend a multi-centered or national study which will account for ethnicity, geographic location, region, and numerous maternal comorbidities. Also, to determine possible confounding variable such as molecular markers or inflammatory markers not measured in this study, to evaluate other dosages applicable to this population and explore its bioavailability. We hope that our findings will inspire more research into the effect of melatonin among infants to prevent or treat NEC. Thank you and have a good day.
Thank you, Dr. Udaki. Now may we ask our contestant and the judges to turn on their cameras and their mics. We can start off with Dr. Magno, and then Dr. Bandong, and then Dr. Guerrero.
Hello, Dr. Daki. I'd like to commend you and your team for successfully completing this clinical trial, and also to the institution for allowing this trial to flourish. And I think the manuscript is well written. I have just a couple of questions. The first is, what do existing guidelines say about treatment of patients with NEC? And does it even include melatonin? And why or why not?
So thank you for the question, sir. So for the current guidelines for treating necrotizing enterocolitis in preterm infant is actually vigilant monitoring, because according to Nelson's textbook of pediatrics, 5 to 10% of preterm infants will develop NEC among those less than 1,500 grams, and the treatment is aggressive antibiotics, placing the patient on and if you will treat everyone with that, that's I think overkill. So you need to monitor and if they show sign of abdominal distension or even feeding difficulties, then we'll start the antibiotics, which will cover for anaerobic bacteria, aggressive fluids, and then we'll place the patient on NPO for bowel rest, because even though breastfeeding is known to prevent or help in the management of NEC, aggressive feeding with these infants will also cause NEC. So that's it, sir.
All right. And then comment on the sample size. You said the target was 100, right? And you reported that in the results you had 100 participants, right?
Yes, sir. Yes, sir.
Right. So how many participants were actually eligible in the first place, and why did you not aim to enroll more participants to account for possible dropouts?
With that, sir, actually, if you can see in my paper, the effect size is actually low at, I think, at 0.5, which is moderate. Actually, one factor is the pandemic. We have a decreased number of patients. Thankfully, I got the 100 patient. It was actually difficult for us to complete. Initially, we were just, pre-pandemic, we can complete this study for 3 to 4 months with the bulk of patients. But because of the pandemic, we have prolong it to 6 or 7 months. So that's the main reason why we limited the sample size for 100. But ideally, we could add 20% attrition to count for possible dropouts. But what we did in the manuscript is because all patients will be admitted, so they would be monitored up until discharge. So thankfully, no patients drop out from the study, sir.
All right. Congratulations to the team.
Thank you, sir.
Good morning. Congratulations. My first question is, what are the confounding variables? How long is the follow-up? And how did you measure or did you document incidence of melanoma or hematochezia for each group?
Okay, for the confounding variables, ma'am, much of the confounding variables were tried to control in the inclusion and the exclusion criteria set, but the confounding variables possibly that could have affected the study would be the inflammatory markers that were not measured in this study, and even other biochemical markers such as ESR, CRP, IL-6. We didn't do it because initially because of the cost. It's really expensive to do those tests. So we relied clinically. For the next question, ma'am, with regards to the melena, it's part of the monitoring sheet because part of the criteria for diagnosing neck is the presence of blood in this stool or even melena, abdominal distension, and pneumatosis intestinalis in X-ray, ma'am. Sorry, ma'am, what was the last question?
Um, uh, did you monitor that and how many patients from the treatment and from the treatment group and the control group had melena
Okay, ma'am.
or
We monitored
hematochezia
the
or any
presence
measurement
of
of your abdominal distension?
we measured it, we monitored it, ma'am, but the diagnosis of neck is collective. For example, for one patient, the patient can have melena, no abdominal distension, no just distension in the abdomen, then we can diagnose with neck. We didn't monitor it individually, but collectively. So we did not itemize the
How many?
symptoms.
It's one
Ma'am?
of the outcomes. What it is one of the outcomes, right? So you have
Yes,
to
ma'am.
report it. Did you report it? What's not
And
included in your table?
it's not part of the table, ma'am. It's just neck because it's under the umbrella of neck na po, ma'am.
Okay, how long was the follow-up for this patient?
For these patients, ma'am, we monitor the patients for 2 weeks. And for 2 weeks for the presence of neck, and then once they were discharged, they were asked to follow up 3 to 7 days after via face-to-face or online. They preferred online, ma'am.
My last question. How many patients were given antibiotics during the hospital stay?
For antibiotics, ma'am, if the patient was already suspected or diagnosed with neck, we start antibiotic, which will cover anaerobic coverage. And for preterm infants that is well and feeding and with no problems, we usually monitor them unless there are risk factors such as maternal infection or if it's thickly meconium stain that really are factors that the neonatologist will consider.
How many of the patients from the control and experimental group were given antibiotics? Because it would be one of their confounding variables.
Sorry, ma'am, we didn't tabulate those, ma'am. We could add it as part of the
Why not?
recommendation. Ma'am, all of those diagnosed with neck,
If
ma'am,
you
for
would,
the
yes, I reviewed the article that your Suleiman et al.
yes, ma'am.
Their one of their the patients were given antibiotics plus melatonin. So my question is, why did you not include the antibiotics?
Ma'am, yes, ma'am. For all patients who were suspected neck, they were given antibiotics, all of them, ma'am. But if they are not yet suspected to have neck and they are well, we hold the antibiotics because it will affect the normal flora of the patient. And if we give antibiotics immediately, that would also affect the normal flora and that could also affect the development of neck unless the patient has risk factors. But once the patient is suspected to have neck, definitely we would give the antibiotics already, ma'am.
And were you able to document among the 50 patients with treatment group and the control group, those were given antibiotics? It
For
will
the
also affect their outcome.
For the treatment group, ma'am, 7 were diagnosed neck,
Yeah, so they were given antibiotics, and for the control group, it was 34, and 34 were given antibiotics, ma'am.
So I think we should also put that in the mind.
Yes,
That's
ma'am.
all.
Noted.
Thank you.
Hi, good morning, Dr. Daki, and congratulations.
Thank you, ma'am.
For my first question, is the use of melatonin to treat neck already, um, is it a usual practice already?
Right now, ma'am, no. It's not a part of the suggested guidelines for the management of neck.
I see. Um, ayan, is there a specific approval that you need to secure before, kasi you're going to be treating um, newborn. Is there a specific approval, higher approval that you would need to get prior to administering melatonin?
Yes, ma'am. Prior to doing the research, we would first have the technical review board of the hospital force the protocol, and then after it was approved, it was sent to the ethics committee of the hospital. Then the ethics committee will determine if the study is ethical or will cause harm to the patient. So we need to give them data such as other researches that show that melatonin is safe to be administered to this population, and they granted us approval, ma'am, to proceed with with the study.
Okay, so aside from the internal, the hospital's review board, basically wala na. There's
Wala.
none other.
Yes, ma'am.
That's it. Okay. Sige. Just just another question. Can one acquire neck after treatment?
Um, for new mom for these patients for prematurity, usually if the neck resolves successfully treated, it usually does not recur for as long as the patient will feed and all the suggestions or the orders of the neonatologist, such as exclusive breastfeeding and everything, is followed, ma'am. But some patients, if they started formula feeding, some had recurrence of neck, but not in these patients. But most of the patients do not have recurrence of neck unless there are other risk factors such as recurrence of infection and that.
Okay. I see. Thank you. Last lang, siguro just a comment. Kasi in your paper, I read that you group the infants according to gender. Basically, pagka newborn, ayan, hindi pa natin siya mag-group to gender. Maybe it's safe to say you group them according to sex.
Okay, ma'am. Thank you, ma'am.
Okay. Thank you.
Thank you, Dr. Daki and the judges. Our fifth presenter is Dr. Moore Villalobos with his paper entitled Diagnostic Accuracy of Frozen Section Biopsy Specimen to a Permanent Specimen, a comparative 3-year retrospective study of Ilocos Training and Regional Medical Center.
Good morning. I am Dr. Moore Villalobos from the Department of Pathology. Today, I will be presenting to you an original study entitled Diagnostic Accuracy of Frozen Section Biopsy Specimen, comparative 3 years retrospective study of Ilocos Training and Regional Medical Center, with my co-author, Dr. Shishar Therese A. Madrid Estuesta. So let's start this presentation with a quote by Wyatt Earp saying, "Fast is fine, but accuracy is everything." The diagnostic accuracy of frozen section as an important source of information in surgical pathology is important not only in the management of surgical patients but also as a measure of quality control in surgical pathology. Frozen section technique was first used by William H. Wells from Johns Hopkins Hospital in 1891 for intraoperative consultation. It was further developed by Wilson McCartney in 1905 at Mayo Clinic. This practice has since then evolved, especially after the development of Priestat in 1959. The main purpose of frozen section is to provide rapid diagnosis to guide intra and perioperative patient management. The indication of frozen sections are identification of tissue in unknown pathological processes, evaluation of origins, identification of lymph node metastasis, confirmation of presence of representative samples for paraffin section diagnosis, and to determine the nature of a lesion that may require ancillary tests. Errors can be divided into errors of interpretation and errors of sampling. These include the initial selection of tissue by the surgeon, the sampling of the tissue by the pathologist, the technical expertise required to prepare the slides, errors in the interpretations or poor interpretations or reading, and the delivery of result back to the surgeons. The aim of this study was to analyze the accuracy of diagnosis of frozen section in relation to its permanent section done in the past 3 years in the Locus Training and Regional Medical Center. Specifically, it sought to find answers to the questions: 1. What is the concordance and discordance rate of the diagnosis of frozen section to permanent section? Number 2. What are the common diagnosis errors of frozen section biopsy? The number of specimens that were included in this study were all of frozen section biopsy results with its corresponding permanent section results in the Department of Laboratories of ITRMC from January 2016 to December 31, 2018. The recommended sample size is 123 with a total population size of 132 and a margin of error of 5% and confidence level of 99%. The study would intend to do total enumeration with purposive samples with only complete frozen and permanent section biopsy results. The tissue specimens were sent to the pathology laboratory during the surgical procedure for an intraoperative diagnosis to be made, and frozen sections were carried out using a modern cryostat machine. The slides were stained with hematoxylin and adacin and reported based on which recommended management was carried out. Subsequently, specimens were fixed in 10% neutral buffered formalin, gross and adequate permanent representative sections were taken according to the standard guidelines. The sections were stained with H&E and evaluated. For those with discordant diagnosis, the reasons were analyzed. Cross-sampling error would include the errors made by the pathologist or surgeon in choosing a sample from the tissue wherein the submitted specimen could be a normal tissue instead of a tumor or non-viable necrotic tissue. These specimens were not representative of a tumor. Second is the misinterpretation of the original frozen section. This would include frozen sections wrongly interpreted as malignant due to artifacts or wrong tissue orientation in assessing the margin. The third, frozen section negative, permanent sections from the frozen block positive. This would include frozen sections wrongly interpreted as negative for tumors due to the lack of obtaining a deeper cut. After routine processing is done, the permanent sections would eventually show the tumor, which was initially absent in the frozen sections because of the superficial cut done. And the number 4, this is the others. This would include other reasons for the discordant diagnosis that don't fit in the definition of the first 3 reasons mentioned. From the 123 specimen section, frozen section biopsy result with its corresponding permanent section results, 123 of the samples were concordant. The result only showed that the 2 methods are perfectly made to meet and accurately check the sections being diagnosed. Experience plays a major role in the interpretation of the frozen sections. There is a lower deferred and error rate when specimens are interpreted by more experienced pathologists. This study showed that there is a perfect concordance rate between the frozen section biopsy and permanent section biopsy used in ITRMC. This study recommends information dissemination of this study that should be further investigated, as a specimen will be taken again to check the evolving diagnostic ability of the 2 methods. Finally, frozen section permanent section biopsy diagnosis method could be assessed on its appropriateness in other kinds of tumor. That would be all.
Thank you, Dr. Villalobos. Now let's request our presenter and judges to turn on their cameras again. So first we will have Dr. Bandong, Dr. Guerrero, and then Dr. Magno to ask the questions.
Congratulations. My first question is, how did you complete for the sample size? What is your sampling time? What is your primary outcome?
Sorry, ma'am, I wasn't able to hear your question.
My first question is, how did you compute for your sample size? Next question is, what is your sampling time? My last question is, what is your primary
With the sample size, it is a proposed sampling. With a total, we have a total of the population of 132 using the rows of software with a confidence, with a margin of error of 5% and confidence level of 99%. We came up with 123 sample size.
What is your primary outcome?
All of our we have a perfect concordance rate on our samples. It's 100% concordance rate.
So your title is accuracy. So there is inconsistency with your manuscript and the manuscript and the title. If it's an accuracy, you have to present it as a sensitivity specificity. And to compete for the sample size, you should use the sensitivity specificity of the frozen section. So I understand that the permanent issue would be the permanent section biopsy would be the gold standard. Am I right?
Yes, ma'am. Yes, ma'am.
This is the surgical issue, right? From the surgeon. Okay, so you have to compete for the sample size. You have to compete for the sensitivity specificity of a frozen section from another article. Then you will use that to compete for the sample size. So since 2016 and 2018, I think you have more than enough of 132 patients who have these patients. I think you should do either random sampling, and like what I said a while ago, your concordance is different from accuracy. So in concordance, it's just agreement between the results. And accuracy is you have to check the 2x2 table, which of your readers agree that this is cancer, those who agree this is not cancer, and those readers that have false positive, false negative. So did you ask for your consultant to for frozen section and permanent section, or you just rely on the official results?
I just relied on the official results from our archive.
Thank you. That's all.
Good morning and congratulations, Dr. Villalobos. Okay.
Good morning.
Part of your research presented the discordant diagnosis. This greatly affects basically test results, diba? This came out as part of your findings. Actually, this is not a question, another recommendation. I was drawn into that because there is an implication on the results that you presented, specifically with the discordant diagnosis. So maybe provide specific recommendations on how the hospital maybe would be able to address such, kasi this is important, especially in patient care and treating the right or having the right diagnosis of such such findings dun sa kinalabasan ng pathological findings ng isang patient. That's it. Thank you.
For my study, ma'am, we have a perfectly concordant tree for the frozen section and the permanent section results. So I'm proud to say that our institution has a 100% accuracy on the diagnosis of frozen section.
Yes. All right. That's good to know. Thank you.
Hello, Dr. Villalobos. So thank you for this paper. I was just struck by the fact that this paper did not indicate what tissues were examined. Did you make a comment on that in any appendix?
The tissues were, in general, we have different specimens like breast, thyroid, skin, and all the tumors. Sir.
Right. And what I did not see that mentioned in your manuscript.
I think it's in the back.
And ideally, it should be presented in the results, the spread of tissues that were sampled, and what was the indication for frozen section. That's one important comment. And I agree with the other judges about the numbers to describe accuracy. If you're going to talk about accuracy, you need some definitions about sensi specie, positive predictive value, negative predictive value. And why did you not choose to focus on one disease entity only or tissue sample? Why did you get everything and lump them all?
Because we will be having less number for the population. So I took all the samples for the 3 years so that we can have a bigger population for this study.
All right, thank you.
Thank you, Dr. Villalobos and our judges. Our sixth entry is entitled Time and Motion Study of Non-Surgical Emergency Room Services in a Tertiary Government Hospital in the time of COVID-19 pandemic. Let us all welcome Dr. Anna Lee Bantasan.
Good morning, I'm Dr. Anna Lee Bantasan from the Department of Community and Family Medicine, here to present my research titled Time and Motion Study of Non-Surgical Emergency Room Services in a Tertiary Government Hospital in the time of COVID-19 pandemic. The emergency department is an integral part of any hospital and plays a vital role in the acute healthcare system. During times of outbreaks or disasters, emergency departments manage influx of patients and serve as main points for triaging patients. This resultant influx may lead to decreased quality of care. However, it is during these times that maintaining efficiency and excellent care is of utmost importance. As such, a time and motion study is needed to ensure adherence to the standards and suggest areas for improvement. This research topic responds to the National and Regional Unified Research Health Agenda and is in alignment with the Universal Health Care, which advocates that every Filipino should be granted access to emergency health services. However, there is paucity of time motion studies of emergency departments in the Philippines. The objective of the study is to determine the waiting and treatment times of patients in the emergency room under the services of the non-surgical departments in the setting of an ongoing pandemic and a revised emergency department setup. Specifically, to describe the average duration of waiting and treatment times, to compare these times to the Citizens Charter, and to determine the factors affecting these times. This is an external observer time motion study, measuring various staged waiting times of medical cases seen at the emergency room by the aforementioned departments in 4 set days. The inclusion criteria are those patients seen by the non-surgical department in 4 days during April 2021. The exclusion criteria are cases needing surgical intervention, those triaged to the OPD, those referred from another institution via ambulance, and your WCPD patients. A data collector tracked patients via CCTV footage, noting the time it takes to complete the following tasks with the use of a stopwatch, and noted variables affecting the duration with a checklist. Results show that 124 patients were observed and monitored, having an average stay of 157 minutes and 7 seconds. This table shows that the first 3 activities takes lesser time and interaction, having a mean duration of 7 to 11 minutes, compared for the rest of the 3 services. This shows that emergency department displays extensive queuing from the moment treatment is prescribed up to the time patient leaves the emergency department. These 3 activities highlighted in green were those that were accomplished within the duration set by the Citizens Charter, showing that these services are well managed. In contrast, the time it takes for the patient to be seen by a physician from the time the blotter is printed takes longer than prescribed. A possible reason for this can be the volume of patients being seen, which can result in imbalance in the doctor-patient ratio, also seen in the studies of Kiriakou and Adam et al. Donning of PPEs prior to patient examination can also impact this service. In the study by Asopardo et al., there was also a delay in the time it takes for a patient to be seen by a physician. However, this was dependent on the priority status of the patient, whether urgent or non-urgent. History and physical examination duration may vary depending on the simplicity or complexity of the patient's condition, taking as quick as 1 minute or as long as 1 hour. The prescription of treatment from the time patient is seen also exceeded the recommended duration, which may still be attributed to the volume of patients being seen by the physician. The study also notes that it takes longer for a patient to leave the emergency department once disposition is determined. Factors that can be attributed to this delay is the lack of rooms or transportation. During the pandemic, there was noted lack of public transportation. In addition, COVID patients would need transportation assistance, but was hampered by the availability of ambulances. Another factor is the transaction of payments and referral to social service. Although some factors are outside the control of the hospital, this still impacts the emergency department services, as these patients take up precious bed space that can be best used by other patients. Factors that affect the duration of the services were laboratory, imaging, and referrals, noted to have a direct correlation to time treatment is prescribed up to the time patient leaves the emergency department. These findings are supported by the study by Asopardo et al. And Yun et al., which also showed that imaging, laboratory tests, and specialty consultation were associated with longer duration of stay. At the emergency department, laboratory as well as imaging can be accessed through computer portals, thus resulting to a service that is incongruent with the duration set by the Citizens Charter. Imaging of COVID cases may have an effect on the waiting times, as ER1 made use of portable X-ray, while imaging at ER2 were scheduled at 6 a.m. and 6 p.m. Noted areas of improvement is to provide designated computers to view and print laboratory and imaging results and to ensure stable internet connection. Diagnostics and referrals impact the time it takes for the patient to leave the emergency department, presumably because of the payment of diagnostic tests and referral to social service. Referrals may cause a delay due to the waiting for separate instructions from the department the patient was referred to. At the time of the study, no published data on time and motion studies were done during the COVID pandemic or previous pandemics that may have an impact on the usual functioning of the emergency department. Overall, ITRMC shows efficient and quality service as majority of services are within the parameters set by the Citizens Charter. However, improving and streamlining the important factors affecting waiting times can result to better quality of service. It is suggested that time and motion studies be carried out in a wide-scale post-pandemic setup to evaluate areas of bottlenecks, particularly in the areas pertaining to diagnostic tests and referrals, and creation of a formal triage tagging. During the time of data collection, La Union was placed on community quarantine which may have affected the number of patients seen at the emergency department. The study did not take into account the patient's diagnosis nor the urgency of the case, as the emergency department do not formally tag the urgency of cases. This research has been funded by the HFDB Research and Performance Management Division of the DOH. I am also grateful for the guidance of my mentors, Dr. Polly Chua Chan and Dr. John Paulette Velasco. Thank you. Maraming salamat po.
Thank you, Dr. Bantasan. Now we may request Dr. Bantasan and the judges to turn on their cameras and their microphones. Let's proceed with the question and answer from Dr. Guerrero, then Dr. Magno, and then Dr. Bando.
Good morning, Dr. Bantasan. Congratulations for this study. Okay, I noted that chronemics in nonverbal communication is reflected in this study. Some recommendations maybe include on how your study may improve hospital processes to be more efficient, although it's already included in your recommendations as I've seen this slide. However, if such recommendations are more specific, maybe it would be more good. I actually appreciate the time in motion studies. Kasi these are process related and procedures related, which can improve quality basically of our health services. Just siguro a simple question. You were not able to note if there's a difference kasi the data was taken during the COVID-19, although we are still in a state of pandemic, pero this was a time in medyo lockdowns pa tayo. The availability of specialists versus that of number of staff in the hospital. Did you consider that in your study?
Thank you for that question. So unfortunately, I wasn't able to take that into consideration. However, the basis for that was just the shifting. During that time, ideally supposed to be, I was going to take that into consideration pre-pandemic, but this study was meant to be done pre-pandemic as a baseline. However, it got in between the pandemic state, so I had to make a lot of revision. And during that time, the changing of the staff was also affected by the pandemic. So I decided not to include that anymore kasi I had difficulty in acquiring data kasi po sa timing of data collection.
Yes, I understand. It would be, I think, part of your recommendation as well to have a study on the pre and post. Sana kung meron tayong data, really pre-pandemic talaga kasi merong lapses, sige, hindi siya lapses, pero merong may pagkatagalan dun sa tatlong procedures, di ba, na ginagawa. Referrals, laboratory, and may isa pa. It's not in my notes. So, maganda siya na makita, baka nung COVID, mabilis na yon. Sana ganun din, di ba? Post-COVID. So, congratulations, Dr. Bantasan. Thank you.
Hello, Dr. Bantasan. Dr. Magna here. Congratulations. I actually resonate with your group's paper because I did similar one when I was in training. And this is quality of care paper that's very important. I am just wondering why you did not detail the diagnosis of the patient. Wouldn't that be an important factor in the lag time before a patient is seen and treated?
Thank you for that, Doc. So actually, this was one of the limitations of my study because unfortunately, it was a pure time and motion study. So I could not track the patient and assign him the bladder. So yung diagnosis po kasi it was written manually in a chart. So it was difficult for us to assign yung patient and then at the same time retrieve yung sa.
Am I correct that you based the time and motion purely on CCTV images?
Yes, po, sir. It was purely on CCTV.
So, and I agree. If you see a patient, you will know who that patient is and what the diagnosis is. What are the chances that the one you're tracking is actually not a patient?
For the CCTV footage, we can rewind actually. So itatrack po tapos we track the patient and um, kung sino yung na-interview ng sa doctor and may management sa kanya. So usually we also coincide with the registration time. Although sa registration time po, it's only the time and the patient.
When you say the treatment was prescribed, it was written in the chart, right?
Yes.
And then the time from the writing of the prescription to the time it was carried out by the nurse, is that right?
For the time it was carried out by the nurse and the time that, for example, if it's a prescription, the time it was carried out by the nurse.
And
Sorry, the
those
time
details you can pick up on CCTV?
Yes po, sir. Kasi we had I actually vetted for a placement of CCTV in the area, so I had to make sure that the
CCTV
areas
is really in place as part of institutional practice or just for your study?
For the study, sir.
For your study. Then what would then be the implication of that in terms of patient privacy and doctor-patient confidentiality, because someone else is seeing the medical data and all the recommendations?
Thank you for that. So actually, we did a non-disclosure agreement for my research assistant, and after we had collected the data, we immediately wiped down the servers. Actually, after 2 weeks, nagre-reset naman po yung system. So after that, I made sure that the CCTVs were wiped clean po. And again, I did a non-disclosure agreement.
Did you attempt to get consent from patients at the ER during that time, or do you feel this was not necessary?
Actually, this was brought out for the ethics since it was we weren't considering the diagnosis of the patient and we were only assessing the process. It was deemed that consent is not necessary just as long as both the researcher and the data collector would sign in on disclosure agreement.
Yeah, well, maybe something that the ethics board has to look into, because if the CCTV is clear, then you can see details about management. So even if you don't know the diagnosis, that's already a breach of privacy, I believe. Anyway, maybe for future papers. Maybe lastly, when you report the waiting times, it would be preferable to include standard deviation.
Yes.
Because it's not enough that you say that the mean waiting time was 7 minutes and 21 seconds, but maybe someone waited for 20 minutes and another one waited for 3 minutes. And the importance of knowing the diagnosis, for example, you said the charter says 9 minutes, right?
Yes.
What if the patient comes in for acute chest pain? You know for a fact that the goal is 10 minutes to an EKG. So if you see the patient at 9th minute, there's a low likelihood he's going to get an EKG in a minute or so, right?
Yes, sir. So that's actually one of the things that I would that was included in my recommendation. So to include the urgency and the diagnosis of the case so that they improve the study. And yes,
All right.
the deviation, it was placed in my, I apologize, it was placed in my research paper, but was not placed in the
Nevertheless, I commend you and the
So
group for coming up with this quality of care study. Thank you.
Thank you for those comments, sir.
Okay, good morning and congratulations. My first question would be, did you consider the shifting of the staff and the weekday and weekend time? Because sometimes weekends will have more patients, and this would affect the turnaround time. And I did not see the triage for patients who will undergo COVID testing, because this time is during pandemic. So time na nag-COVID testing for RT-PCR or yung timing na
So thank you for that, man. For the first question regarding shifting, it was actually in my paper. Again, sorry, I wasn't able to include it in the PowerPoint because of timing issues. But yes, it was found that for days of the week, there was significant some activities that were compared to the weekday. So I think this was the um, time of the patient enters the ED up to the time that the blotter is printed. However, this is opposite during weekdays because in some there are some cases wherein there are longer queuing times, especially in time of disposition. So, however, these times were not significant. So for the shifting, again, the times were not significant, but it was noted that in 7 to 3 and 3 p.m. shift, there was a longer queuing time overall compared to the 11-7, probably because of the greater volume of patients seen in 7 to 3 or 3-11 shift. And for the, sorry, what was the second question, ma'am?
time interval for the COVID test.
For the COVID testing, so for...
Where is yung time na yun? Kasi ba once patients enter, tapos time yung blood or time na they would go for the testing because all patients who will go to the ER are COVID suspects regardless may symptoms or wala.
So actually for our setup, ma'am, not all patients would undergo testing. So actually the ER1 and ER2 are separate. ER2 would handle your infectious cases and they would not really require testing prior to entry to the hospital. They would only do COVID and if the patient would be discharged, the COVID swabbing would be coordinated to the LGUs or the local healthcare provider network.
I think all patients should undergo COVID testing regardless if symptoms are not. Kasi it's one of your patient safety and safety of the staff. Dapat kasi yun din yung pa rin kasi. Then in some cases dito sa I don't know, in some cases they have 2 ER. So ER then first ER is all patients are suspected with COVID. Kunyari, they would test them. Then if it's sure that the ER, yun dapat medyo you have to take a look kung pwede yung maging part ng algorithm ng ER. And yun, I agree with the other judge that regarding the Data Privacy Act, yung kasi yung CCTV, dapat beforehand inform the patient that it is okay for them to be recorded. Kasi kung nakapagkuha kayo ng informed consent, then you can get the diagnosis. It will also help your in assessing the patient, the urgency of the cases of the patient. That's all.
Thank you, ma'am, for those comments and suggestions. We'll take that into account.
Thank you, Dr. Bantasan and the judges. And now, as all our contestants have finished their presentations, we come to an end on our contest proper.
All that's left is for our judges to deliberate and for our colleagues here in the hospital research unit to tabulate the scores.
While the rest of us wait anxiously for the results, allow us to use this time to extend the hospital research unit's sincere thanks to our presenters and judges for their time, effort, and dedication to research.
As a token of our gratefulness, we present to you these certificates of appreciation, the contents of which will be read by Dr. Joel Beleno, Chair for Representation and Linkages.
Thank you very much, Dr. Esperon and Dr. Joanna Nang, for this opportunity. Thank you very much to all our judges and our participants in this year's annual research forum. the Ilocos Training and Regional Medical Center Hospital Research Unit would like to award the certificate of appreciation to our judges. Let's start off with Dr. Irene Abigail S. Guerrero for sharing her expertise as a judge at the 21st at the Annual Research Forum Original Studies, given this 23rd day of March 2022 at the ITRMC, City of San Fernando, La Union. Signed by Dr. Lala Bambico, Chair of this Annual Research Forum 2022. Signed Dr. Alan Corpus, our Chair of the Hospital Research Unit. Signed also by Dr. Mario Gerardo Tolentino, Head of the Petro, and of course our Medical Center Chief, Dr. Eduardo Padua. And we asked Dr. Guerrero to open her camera and receive the certificate, virtual certificate. Thank you very much, Dr. Guerrero. May we hear a word from you, short message?
Good morning, I thank the organizers for extending an invitation to me in being a judge in this research congress, medical research congress. I really appreciate the studies that our participants have presented today. I'm sure that there are a lot more researches readily available in the institution, and we're looking forward for more purposive studies from the group. Thank you, everybody.
Thank you, Dr. Guerrero. Our next judge, the Ilocos Training and Regional Medical Center Hospital Research Unit awards the certificate of appreciation to Dr. Irene S. Bandong for sharing her expertise as a judge at the 31st Annual Research Forum Original Studies, given this 23rd day of March 2022 at the Ilocos Training and Regional Medical Center, City of San Fernando, La Union. Signed, Dr. Lala Bambico, Chair of the Annual Research Forum for 2022. Signed, Dr. Alan Corpus, Chair of the Hospital Research Unit. Dr. Mario Gerardo Tolentino, the Head of the Petro, and Dr. Eduardo Embado III, Medical Center Chief. Can we ask Dr. Bandong for a short message? Thank you, Dr.
Good morning. I would like to thank the organizing committee of the Annual Research Forum of Ilocos Regional Training Hospital, and I would like to congratulate the residents as well as their mentors for their good manuscript.
Thank you, Dr. Bandong. And last but not the least, we'd like to award the certificate of appreciation to Dr. Jose Donato A. Magno for sharing his expertise as a judge in the 31st Annual Research Forum Original Studies, given this 23rd day of March 2022 at the Ilocos Training and Regional Medical Center, City of San Fernando, La Union. Signed, Dr. Lala Bambico, Chair of the Annual Research Forum. Signed, Dr. Alan Corpus, Chair of the Hospital Research Unit. Signed, Dr. Mario Gerardo Tolentino, Head of the Petro. And signed, Dr. Eduardo Embado III, Medical Center Chief. Congratulations and thank you, Dr. Donato Magno, for this opportunity with you. Can we hear a word from Dr. Magno?
Thank you, Dr. Joel. And I have such high respect for the institution that puts premium on research, and this was really a masterful display of organizational skill. I'd like to a special shout out to Dr. Lala, Anna, and Alan, my colleagues, and to all the organizers, the investigators, their mentors. No? I hope you proceed not just with presentation, but bench to bed, which means you translate this to better patient care. But the first step there is publication. So congratulations to everyone.
Thank you. That's very well said, Dr. Magno. That is actually our vision, to have policy translation of all these research outputs that were presented today, and in the succeeding research presentations. So thank you once again to our judges. Hope this will not be the last time that you are joining us. Hopefully, we can have you some other time again in the future. Thank you. Now let's award our certificates of participation to the different to the presenters of today's forum. Let's start off with Dr. Odani Gemma Frances Marconi. Can we ask her to open her camera as we award her certificate? The certificate of participation is given to Dr. Odani Gemma Frances Marconi for being one of the participants in this year's annual research forum original studies. Signed, Dr. Lala Bambico. Signed, Dr. Alan Corpus. Signed, Dr. Mario Gerardo Tolentino. And signed, Dr. Eduardo Padua. Thank you, Dr. Raudani. Let's have the next participant. The certificate of participation is awarded to Dr. Modesto David Bolislis, for being one of the participants in this year's annual research forum. Given this 23rd day of March 2022 at ITRMC San Fernando City, La Union. Signed, Dr. Lala Bambico. Signed, Dr. Alan Corpus. Signed, Dr. Mario Gerardo Tolentino. And Dr. Thank you and congratulations, Dr. Modesto Bolislis. Next, I'd like also to give the certificate of participation to Dr. Vivian Marie P. Abitong for having actively participated in this year's annual research forum, given this 23rd day of March 2022 at ITRMC. Signed, Dr. Lala Bambico, Dr. Alan Corpus, Dr. Mario Tolentino, and Dr. Eduardo M. Padua. Congratulations, Vivian, and thank you. Next up, this certificate of participation is given to Dr. Navid P. Rodaki for having actively participated in this year's annual research forum, given this 23rd day of March 2022 at ITRMC, San Fernando City, La Union. Signed, Dr. Lala Bambico, Dr. Alan Corpus, Dr. Mario Tolentino, and Dr. Eduardo M. Padua III. Thank you, Dr. Rodaki. And last, second to the last. This certificate of participation is given to Dr. Moore Villalobos for having actively participated in this year's annual research forum, given this 23rd day of March 2022 at ITRMC San Fernando City, La Union. Signed, Dr. Lala Bambico, Dr. Alan Corpus, Dr. Mario Tolentino, and Dr. Eduardo Embado. Thank you very much, Dr. Villalobos. And last, we have Dr. Annalie Bantasan. We award the certificate of participation to you for having actively participated in this year's annual research forum, given this 23rd day of March 2022 at ITRMC, San Fernando City, La Union. Signed, Dr. Lala Bambico, Dr. Alan Corpus, Dr. Mario Tolentino, and Dr. Eduardo Embadua. Thank you very much, Dr. Annalie Bantasan. Thanks to all of you. Thanks to all our participants and our judges. Back to you, Dr. Esperon and Dr. Joanna.
There you have it from Dr. Bileno. So in the field of research, nothing is more reassuring than a good remark from a seasoned researcher. Here to greet us all is our very own Chief of Medical Professional Staff, Dr. Unity Cortez.
So we will be hearing from Dr. Cortez in a bit. This worthwhile endeavor would not have been made possible without the help of our friends from Servier Farm.
Let us know more about their innovative products and services with this presentation.
Good afternoon, doctors. I hope that you can hear me well. I am Clara, and here with me is Robbie, my counterpart, and one of our area managers, was transforming doctors. We are from Certainly Philippines, and it is an honor to be part of ITRMC's annual research forum, and we thank you for this opportunity. As part of Certainly's commitment to therapeutic progress through innovative research, we are here to share some relevant updates to serve your patients' needs. So I would be sharing my slide already. I hope that you can see my slides. Thank you. So doctors, you can protect all your patients from multiple cardiovascular risks with the unique guideline-based single pill combination of atorvastatin, perindopril, and amlodipine trivaram. With trivaram, you can be assured of proven cardiovascular protection, round-the-clock BP and LDL control with better treatment adherence. And I'm sure also, doctor, that you do also value the management of your patients that are uncontrolled hypertensive patients. You can rev up the power to control the BP of your uncontrolled hypertensive patients with the only triple combination with indapamide, which is triplex with consistent cardiovascular protection, more powerful and safe BP control, recommended by guidelines, better than ARBs. And I would also like to call on again, Robbie.
Thank you so much, Kara, and good morning, doctors. So first, in line with the single pill solutions of the hypertension franchise of Servier, doctors, we also have Viacaram Initio and Viacaram 7x5 for newly diagnosed and type 2 diabetic, newly diagnosed grade 1 hypertensive patients and hypertensive patients uncontrolled on ARB or CCB monotherapy. So doctors, more patients would enjoy the effective BP control and early vascular protection with Viacaram Initio and Viacaram 7x5 due to its more affordable pricing. Again, doctors, to enjoy these benefits, Viacaram Initio is now priced at 20.50 pesos and Viacaram 7x5 at 24.75 pesos. And moreover, doctors, aside from hypertension, we know that you also encounter hemorrhoidal disease patients, and that's why we have now released the new and convenient Daflon 1000 milligrams MPFF. So for hemorrhoidal disease patients across all clinical stages. So initiate the Daflon 1000, doctors, to all clinical grades of hemorrhoidal disease patients to provide powerful efficacy, prevention from relapse and recurrence, to provide convenience and better adherence. And also, doctors, ang bago pong dosing with the Daflon 1000 is a CCS 321. 3 tablets daily for the first 4 days, 2 tablets daily for the next 3 days, and 1 tab OD for at least 3 months for the maintenance. So that's for my part. And now we will call on our area manager to again provide another relevant product update.
Thank you, Kara, and thank you, Robbie. So doctors, for your trimetazidine-naive angina patients, such as the newly diagnosed or those on hemodynamic treatments, start with the first and only 80 milligram trimetazidine with highly advanced controlled release technology, Vasteral OD 80 milligram 1 capsule daily. So doctor, by increasing the energy directly at the cardiac cell over 24 hours, Vasteral OD 80 milligrams for doctors would give you reliable round-the-clock anti-anginal efficacy. And cardiac protection, providing more powerful angina control and better treatment adherence. Thank you, Karen. Next slide, please. And doctors, moreover, to achieve target heart rate of your angina patients, prescribe Coralan to all your angina patients with elevated heart rate of equal to or greater than 70 beats per minute for faster and powerful reduction in angina attacks compared to beta blocker alone, lowers the risk of adverse events compared to beta blocker titration, and reduce risk for hospitalization due to MI, and consistent efficacy and easy to use in broad range of patients. So again, doctors, thank you for giving us this opportunity to partner with you with this meeting. So again, all our survey products are available in the nearest Mercury outlets. So thank you so much, doctors. Thank you, Kara and Robbie. Thank you again, dear doctors, for this opportunity. I would now turn it over again to our host. Thank you.
Truly, it has been a really informative research that has been presented. So now, may we call on the chair of our research committee to give some inspiring message, Dr. Alan Corpus.
Hi, good morning, everyone, and thank you for gracing our 31st Annual Research Forum and our second virtual research forum. So, first of all, I'd like to express my appreciation to the panel of judges, of course, to my senior and my mentor, Dr. Donnie Magdo. Thank you so much for gracing this event. We appreciate your time and all the inputs that you've given us this morning. It just feels like going back to the halls of the Philippine General Hospital and learning from you again. So it's always a pleasure to have you, sir, around and learning from everything that you have to teach us. Also, I'd like to thank Dr. Abby Guerrero and Dr. Irene Bandong for spending time with us. Thank you for taking time to review the manuscripts and give your inputs to our researchers. It's truly valuable to listen in to great minds in research in order to improve our papers, and not only that, but also to build a strong research culture in the hospital. My gratitude also goes to the technical team of the Laws Training and Regional Medical Center, as well as as a special thanks to Sir Peter and Joanna Nang, who helped us in the production. So we're really grateful for first class production this morning. So thank you so much for taking time to edit the presentations, to work on the technical aspects of this morning's annual research forum. And of course, to our energetic research assistant Hazel and our biostat Ma'am Mary Ann. Of course, I'd like to congratulate Dr. Lala Bambico, who's the overall chair of this annual research forum. So, as Dr. Hannah mentioned earlier, we would like to continue building a research culture in the hospital. And this starts with small things, and that's to look into the things that are important each day, the things that we usually miss, the cases that we see in the hospital. These things actually build information as we tend to, as we try to focus on the little details. And research is just, as I always tell everyone, it's just digging deeper into the aspects of small things. So, minsan nakala natin very highfalutin yung research, but in fact, we do it every day. The mere fact that we Google a lot of stuff, that we go into Facebook and social media and take a look at a lot of things happening around us, that's research. And clinical research is just shifting that kind of curiosity into the medical field. So I congratulate all of the presenters this morning. We hope that next year we will be including more participation from the other departments of the hospital. So thank you, everyone, and good morning. And again, my congratulations to the presenters.
Thank you, Dr. Alan Corpus, for that very much needed response and for being adamant as a chair of the research committee. So now, the moment we've all been waiting for.
Tabulations have been completed. We have our winners.
Please be reminded that our judges' decisions are final with our distinguished panel's combined wisdom, experience, and expertise. We are confident that they have made the best decision.
And finally, fellow doctors, ladies and gentlemen, for the announcement of winners, here is Dr. Marjorie Rimando, Assistant Chair, representing.
So good day, everyone, and congratulations to our participants who presented their original research papers at our 31st annual research presentation at Ilocos Training and Regional Medical Center. And I am proud to announce this year's winners in our annual research forum. So let me first read the content of the certificates. So can we flash the certificate? So the certificate of recognition will be awarded to the best presenter and winners in this year's 31st Annual Research Forum. original studies, given this 23rd day of March 2022 at Ilocos Training and Regional Medical Center, City of San Fernando, with the following signatories: Dr. Lala Ann Bambico, the Chair of the Annual Research Forum 2022, Dr. Mario Gerardo R. Tolentino, the Head of the Profession, Education, Training, and Research Office, Dr. Alan D. Corpus, the Chair of the Hospital Research Unit, and lastly, Dr. Eduardo Chief. So the moment that we've been waiting for, so are we ready? Again, all of you are already winners, so get to know the winners. Now, for the best presenter, garnering an average score of 91.67% goes to the Department of Pediatrics, Dr. Navid P. Rodaki. Kindly open your camera for documentation, Dr. Rodaki. Thank you, Dr. Rodaki. Now, moving on to our placers. So the third place is awarded to the Department of Radiology, Dr. Odani Gemma Francis Marconi. Kindly open your camera, Dr. Marconi. Congratulations. Thank you, Doctor. So moving again to our second place goes to the Department of Community and Family Medicine, Dr. Congratulations, Dr. Annalie D. Bantasan. Thank you, Doctor. And now for the much awaited first place in this year's research contest, garnering an average score of 89.67% goes to the Department of Pediatrics, Dr. Navid P. Rodaki. Congratulations. Dr. Navid, kindly open your camera.
Congratulations, Dr. Rodaki. Thank you po.
Congratulations to your mentors.
Galing. And Dr. Daisy po, especially Dr. Daisy and the department po. Thank you.
So indeed, a fruitful morning for everyone. Thank you for everyone who joined and participated. Turning the floor over to our MCs, Dr. Esperon and Dr. Nam.
In the field of research, nothing is more reassuring than a good remark from a seasoned researcher. Here to greet us all in our very own Chief of Medical Professional Staff, Dr. Unity Cortez.
Hello, good afternoon, everyone. Okay, first of all, in behalf of the whole ITRMC and the medical division, I would like to extend our deepest gratitude to the panel of judges for being with us in this very important research activity. Your collaborations and your mentoring, and of course, your valuable inputs on the cases presented by our residents definitely are very important in how we're going to improve research outcomes from our residents. Let me also thank our health research unit of the hospital, headed by Dr. Alan Corpus and his team, particularly Dr. Lalaan Bambico, who chaired this annual research forum, to Dr. Mauricio, Dr. Casino, Dr. Joel Beleno, Dr. Marjorie Rimando, and of course to our gorgeous, handsome, and beautiful host, Dr. Nang and Dr. Esperon. Thank you for your support in all the activity of the hospital insofar as research is concerned. As your CMPS, and at the same time, the chairman of the Region 1 Health Research Development Consortium, capacity building, it's very important for us to really look in the way we support our residents in the development of research with foremost objective in mind, that it will help our research beneficiaries. So as a way of giving you a better and good insight on what is the real reason why we are doing health research, of course, is to improve the health outcome of all Filipinos, particularly the patients that we serve here in the region, particularly also in the province. So always keep this in mind, that after presenting and congratulating, of course, I would like to congratulate all the winners, but all of you are winners. You have to continue the passion of doing research. Do it not because of a requirement for your residency training program. You do it because you want to contribute something, and that is to improve the health outcome of our research beneficiaries. So do not lose that passion, that fervor, or that alab, as we are now saying that we can be the Silag Ti Amyanan. Our hospital is the Silag Ti Amyanan of Region 1, but our employees, particularly our young colleagues, doctors, even as you age like I am now, I still really a very passionate advocate of research. So with that, again, congratulations to all of you, and I hope that you continue writing your research. Please give it to me so I can endorse it for funding, hindi lang po from the Region 1 Health Research Development Consortium, but we can ask funding from our partner agency, particularly from the Department of Health. Maraming salamat, mabuhay po kayong lahat. ITRMC, Silag Ti Amyanan, basta sama-sama po tayo, kayang-kaya nating lahat ang ating ma-achieve ang ating mga goals. Good afternoon, thank you so much. Back to you, our host.
Thank you, Dr. Unity Cortez, for that valuable and sincere remark. So, congratulations to all our winners. I can feel the joy and relief. They were all well-deserved. And congratulations to all our contestants. Through all your hard work, you continue to prove that our doctors here at ITRMC are indeed capable researchers in their own right.
Indeed, as we move forward to realizing our hospital's vision to becoming the Silag Ti Amyanan, we recognize that research plays an integral part of our role, not only in the scientific community, but in how we interact with and treat our patients as well.
We may yet find that through research, world-changing innovations and discoveries might come from our ranks.
And as we are reminded at the beginning of this day, research is a basic skill that is necessary for all of us as practitioners of the medical field.
And as all things must come to an end, to give us our final message and closing remarks, Dr. Lalaan Bambico, the chair of this year's annual research forum.
Hello. So thank you, Dr. Joanna and Jay, to our Medical Center Chief, Dr. Eduardo Baidua III, Dr. Unity Cortez, our CMPS, our Petro Head, Dr. Jerry Tolentino, Dr. Amy Sanchez, our Ethics Head, and Dr. Alan Corpus, our Research Unit Head, our distinguished Board of Judges, our HRU family, department heads, ITRMC family, survey, good morning. First, I want to thank all of you for joining this year's Annual Research Forum, to our Medical Center Chief and the heads for all the support that you have extended to the HRU family. We are very grateful. From the encouraging words to the approval of our yearly budget that enable us to finance projects such as this. To our residents, consultants, and department heads for their efforts to come up with good papers that are not only a requirement for the residents to pass and graduate, but worthy to be presented in different research fora such as this. We've come a long way. I remember myself being invited to join the research group in the hospital a few years ago, and really a lot of things happened. From the research training with Dr. Dans to now heading this research forum, I can really say that we made a leap in the way our hospital do research. Look at how our organization expanded through the years, not only number, but functions too. We are now licensed to do clinical trials headed by Dr. Hannah Corpus. We have the Ethics Research Committee family headed by Dr. Amy Sanchez. We have invited great mentors and researchers to our hospital as judges in person and virtually. We now have a biostat in the office, and of course, a very conducive and beautiful workplace. Second, congratulations to all our contestants, their co-authors, and department heads. I have attended the different departments' research presentations for the past 2 years, and I am proud of what I have seen. How you come up with a program with all of your consultants listening and eager to ask you questions, and not about your patient's lab test, your surgical technique, your morbidity or mortality census, but about your research objectives, your methodologies, data, and tables and results. I knew how difficult it is to come up with papers at a very difficult time, such as what we had for the past years during the COVID, but you were able to conquer that and able to deliver your papers so you can tap your backs and say to yourselves, job well done. Lastly, to the HRU family, I appreciate all of you for all the efforts that you've extended, for sharing your precious time with us, for every paper that you've checked, every training that you've attended to be more equipped, the guidance that you've given your residents. Thank you very much. Thank you for your devotion. I hope that we can enjoy this journey as a family, and I pray that we can produce more quality papers that could help us in our policy making in this hospital and the country. Again, thank you and good morning, and see you all next year. Thank you.
Thank you, Dr. Gambito. Before we officially end today's activities, we would like to request all of our participants to turn on their cameras for our photo ops. Please remain smiling as we scroll through all the participants, as we're not sure which page you will be photographed on.
Thank you, everyone. And as a final announcement, all plaques, certificate, and prizes will be given on Friday, March 25.
Smile, everyone.
Okay na?
Have a wonderful day, and we have been your hosts, Dr. Joanna Nang
and Dr. John Richard Esperon, now signing off.